Hello and welcome. Let's talk about aminoglycosides. Now, these are the bactericidal drugs which are broad spectrum. They inhibit protein synthesis. These drugs include streptomycin, neomycin, kanamycin, amikacin, gentamicin, tobramycin, cecimycin, and netilmycin. The source: the Streptococcus griseus is the source for streptomycin, and mold micromonospora is the source for netilmycin and gentamicin. Chemistry: the aminoglycoside consists of hexose aminocyclitol ring, either streptidine or 2-deoxystreptamine, to which various amino sugars are attached by glycoside linkage. Now, general properties: all are bactericidal, it inhibits protein synthesis, all are basic polycation and highly polar compound. The absorption from GIT is very poor because of ionization and must be given parenterally, mainly extracellular. It is water soluble and stable in solution. All are ototoxic and nephrotoxic, more active at alkaline than at acidic pH. These are essential and cheaper drug, and they demonstrate concentration dependent killing and also have post antibiotic effect. Now, mechanism of action: there is irreversible inhibition of protein synthesis. All aminoglycosides enters across the outer cell membrane by passive diffusion via porine channels. The drug is then actively transported into cell by an oxygen-dependent process coupled by a proton pump. Inside the cell, aminoglycoside bind irreversibly to specific 30S ribosomal subunit and inhibit protein synthesis at least by 3 ways, either by interference with the initiation complex of peptide formation or by misreading of the mRNA, so incorporation of the incorrect amino acids into peptides occurs, or by breakup of the polysomes into non-functional monosomes. Now, this is a picture showing the mechanism of action where 30S subunit is the process by which this drug works. This is another picture showing the mechanism of action in cellular level. Now, pharmacokinetics: the poorly absorbed drug from GIT, but it is highly polar and polycationic compound. It must be given parenterally by IB or IM, and it is mainly distributed extracellularly. It not introduced into CNS, CSF, and eye. The concentration is very high in renal cortex, endolymph, and perilymph of the inner ear. The serum half-life is 2 to 3 hours, and it increases to 24 to 48 hours in patient with renal impairment. It can cross the placental barrier and may accumulate in the fetal plasma and amniotic fluid. It is not metabolized but excreted through kidney mainly by glomerular filtration, and clearance is directly proportional to creatinine clearance. Excretion is greatly decreased by the renal function impairment, and it has concentration dependent killing and post antibiotic effect, so can be given once daily dosing. Now, antimicrobial activity and clinical use: it is effective primarily against aerobic gram-negative organism. It is effective only against aerobic organisms because anaerobic organisms lack oxygen-dependent transport process. It has no role as initial therapy of the gram-positive organism and must be given in combination with penicillin and others. Gentamicin, amikacin, tobramycin are most widely used, while neomycin and kanamycin are topically used. Now, gentamicin: it is given in case of the serious infection like sepsis, meningitis, UTI, and others. And it is a drug of choice in case of the gram-negative septicemia. And in case of the abdominal and pelvic sepsis, it is given as a combination therapy, where gentamicin is given with beta-lactam antibiotics or metronidazole, or gentamicin is given with beta-lactams or metronidazole. In case of bacterial endocarditis, gentamicin is given with benzoyl penicillin or ampicillin. In case of the streptococcal endocarditis and Staphylococcus endocarditis, they are also given. For the treatment of the infected burn wounds and prevention of the intravenous catheter infections, topically it is given. Now, tobramycin: it is more active against Pseudomonas, and it is less nephrotoxic than gentamicin but more expensive than gentamicin. It is used similar to gentamicin, and also in case of the infective exacerbation of the cystic fibrosis caused by the Pseudomonas aeruginosa, which is commonly used by a nebulizer. Streptomycin: it becomes resistant to most organisms, so limited chemical use is seen. TB caused by mycobacteria is the second line agent. Non-TB infections in combination with oral tetracycline and in case of the enterococcal endocarditis in combination with penicillin. Neomycin is not used systematically because of the serious toxicity and lower efficacy, but it is used clinically in case of topical for infected surface or injected into joints, pleural cavity, tissue spaces, oral cavity. It is combined with neomycin, polymyxin B and bacitracin. Oral. For gut sterilization, neomycin and erythromycin is used prophylactically in the preparative period of the patient undergoing colorectal surgery to reduce the bacterial load. And in case of the hepatic gamma, it is also used. Paromycin is used in case of the intestinal amoebiasis, and amikacin is active against gentamicin and toromycin resistant organisms, and it is active against multi-drug resistant Mycobacterium tuberculosis. Now, clinical uses of the aminoglycosides include serious infections like sepsis, meningitis, UTI, and others. In case of the gram-negative septicemia, abdominal pelvic sepsis, bacterial endocarditis, which may be enterococcal, streptococcal, or staphylococcus, or infective exacerbation of the cystic fibrosis, or TB because of mycobacteria, plague, tularemia, brucellosis, or in case of the topical administration for gut sterilization or hepatic coma, and in case also of the intestinal amoebiasis. Now, the side effect includes neurotoxicity, the neuromuscular paralysis. Aminoglycoside also decreases the release of the acetylcholine. It may release allergic reaction like fever, skin rash. The contraindication includes myasthenia gravis with muscle relaxant, with other nephrotoxic drugs, with other autotoxic drugs, and pregnancy. Spectinomycin is structurally related to aminoglycosides but lacks amino sugars and glycosidic bonds. It is used as alternatively for drug-resistant gonorrhea or gonorrhea in penicillin allergic patient. The toxicity includes pain in the injection site, nephrotoxicity, and anemia. Extended interval aminoglycoside dosing (EIAD) is a traditionally aminoglycosides have been administered in 2 to 3 doses, daily doses for patients with normal renal function. But nowadays, aminoglycoside dosing has been designed on extended interval, usually given in once daily dosing. Advantage is single large once dosing, better efficacy, less toxic, and cost effective. Antibacterial effects depend mainly on the peak drug level rather than time. It can be given because of two properties like concentration dependent killing and post antibiotic effect. So why aminoglycosides are bactericidal? Because these are irreversible inhibitor, have concentrated dependent killing, and have post antibiotic effect. End of the topic.